All right. Well, it's 6:01, so we typically get
Yeah.
a couple more people that'll jump on as time goes on, but we're already up to about a dozen or so that's great. So I really appreciate everybody who's joining. Welcome to our virtual community lecture series, which has become a monthly event, which I really enjoy. So I asked Dr. Alex Papa, who I've worked with for many years, to join me. So he runs our Lifespan Cancer Institute, which is the cancer center at Newport Hospital, and we'll talk a lot about that. But just a little bit of background about Dr. Papa. So he got his MD degree from Brown University. So he's kind of a local if you start from that standpoint, I guess. We were just talking as people were logging on that he started his practice here in Newport in July of 1991. So 3 decades of service to Newport, which is amazing. And I know that's something that we're all really proud of. You did your residency. You did a couple of hospitals in Connecticut. That was plugged in with the Yale system at the time, right? At Danbury and Griffin.
Correct. Yeah.
Yeah, and then your fellowship at Roger Williams. So back to Rhode Island for some hematology oncology training. So for those of you that don't know Dr. Papa, he's a hematologist oncologist, so a specialist in the various disorders of the blood as well as cancer type disorders. And so we can talk about all those different things if you're interested. If you that don't know me, I'm Jeff Gaines. I'm an emergency doctor, and I worked with Dr. Papa in that capacity for about the last 12 or 13 years. We also sit together on the medical executive committee and some of the leadership roles within the hospital. So Dr. Papa has been instrumental in lots of decisions on where Newport Hospital goes and making sure we're doing the best we can for the community we serve. And so I'm the chief medical officer at the hospital now, and I'm excited to have Dr. Papa on our little program. Just a couple of logistics for those that haven't joined the community lecture series before. So I'll moderate, which means I'll just sort of introduce Dr. Papa like I did. I will put myself on mute for a little bit. I'll keep track of the chat box and the question and answer. So if you look at the bottom of your screen on most devices, on an iPad, it might be on the top, but you should see a little bubble with the Q&A and a little cartoon bubble with the chat. You can use either one that you like, and you can put in questions there. Right now, you won't be able to bring yourself off mute and talk. Just give Dr. Papa a chance to chat a little bit. And we thought we'd kind of give you a little introduction as to what's been going on lately at Newport and what's going on with the Cancer Institute. But then what I'll do is you can certainly type in questions if you're more comfortable. Or if you want, what I'll do is I'll just click the allow to talk function and allow everybody to kind of unmute. And I thought it'd be a great opportunity to just have a little conversation with Dr. Papa, which is a pretty rare opportunity with a specialist like him, with his experience in hematology and oncology in the cancer center here, and decades of experience, 37 years from my math of doing this. So he's learned a thing or two across the time, and you don't often get a chance to really just sit down and ask questions. So hopefully you'll take up that opportunity. I've got a few of my own if we don't cover it, just because I'm curious his thoughts on things as well. So without much further ado, please type questions at any point in the chat box, the Q&A box. When the time is right, I can jump in and ask Dr. Papa those questions, and then we'll unmute and let everybody chat, and we'll have a nice conversation. So without that, anything extra, I will pass it off to Dr. Papa. Thank you again for having the time to do this. This is great. Really appreciate it.
Thank you, Jeff. I really enjoyed doing programs like this. And the reason that I chose this format is in the past, I would give lectures on a certain topic. And, you sort of fill up the time, talking about the various aspects. And I really like looking, in the days when we had an audience out there looking at the faces. And I realized, you go on and on about a certain topic, and then you get to the last few minutes, and there's always a million questions. And I often wondered, did everyone get their question specifically answered? Because the topics are broad, even disease by disease. It's not one size fits all. So a few years ago, I decided, why don't we do it the other way around? Let's do questions first. And you basically can ask whatever you want. Because anyone that's motivated to come to a format like this, or, be it a live lecture or now virtual, usually has something in mind that they want to address or ask or just know about, and I was blown away by how popular that was. Everyone had something, and we weren't confined by the last 5 minutes for questions. So when Dr. Gaines asked me again, I said, well, why don't we use that same format? I will introduce a little bit. We have when I did the previous talks, I was still affiliated. I've always been affiliated with Newport Hospital, but I sort of had a private practice. In 2014, we formalized the Lifespan Cancer Institute with all three hospitals, and we have our own dedicated cancer institute here at Newport Hospital. We were originally on the 5th floor, but in March of this year, we moved to the 1st floor, a nice, bright, open unit. And basically, we can treat or handle all kinds of cancer issues. Majority we can handle here. If you need some special expertise or things that we don't quite have here, we have usually a seamless mechanism to get that done. So this is where you start, and this is where you should go. And it's not just cancer, it's blood problems too. In fact, there are more patients out there that have blood disorders than cancer, just because the nature of blood disorders are more common. And we handle those as well. In fact, I probably do more blood issues than cancer at the moment, just by default, really, because there's more out there. And some of my colleagues, Dr. Ingham, Dr. Safran, Dr. Dizon, who all come here, do more of the cancer side. But basically, I'm very proud of this unit because you don't have to wonder, can they handle this? Can they do that? Is my cancer, is my blood problem something that can be handled? You just show up and we'll figure it out. Majority will be taken care of right here, right on the 1st floor. If you need radiation therapy, specialized treatments, the vast majority are treated within our Lifespan system, and we have access everywhere. The nice thing about oncology and hematology is that all providers throughout the world, the processes that we treat are bigger than us. There's no one-upsmanship. The patient at hand, no matter who we have to talk to get the right care, we do it. So, and it works very well here.
I love that idea. And it's such a nice ability to have that connection up north if we have super specialists and things that we might not have on site, which is awesome. And speaking of super specialist questions, there's one that I certainly wouldn't be able to answer in the chat box. So what I might do just for fun is, as long as folks are comfortable, I actually have a trick that I can promote people to be panelists too. So I think for people that have questions, if you feel comfortable, that way I can bump people up and we can actually maybe even be able to see them. So let me see if I can pull that off. I don't know if you can see that, Alex, in the chat box. There was a question about notifying patients if you think they should get a booster shot for COVID. And I know there's been a lot of talk about that. Do you mind talking a little bit about maybe immune compromised patients and normal patients? And then I know a little bit about what's going on just from the healthcare space, but
right. Sure. We fielded a multitude of questions in the past few days. I think the government has made it easier. Basically, anyone that's under treatment for cancer, has an immunodeficiency, or recently has had a cancer-related problem or an immune-related problem, should get a booster shot. So we were already formulating who, how, and when we were going to do it, and then the I don't know if it was CDC or the FDA or a combination, so that they would start a booster program, basically greatly expanding that, which made me very happy because I didn't see the point in giving a booster to a patient and then their spouse or other people in the household, weren't getting it. It sort of didn't make sense. So I would broaden it out. I think there'll be probably an age criteria, maybe over 50 or over 60. So you don't have to worry if you're immunocompromised or not, or everyone I think is going to be eligible and should get it.
Yeah, that's exactly the news that I've been hearing too, is I think boosters will follow the similar path that we did on the initial round of vaccines in terms of highest risk and people that are most vulnerable. And right now, as I understand it, it's considered kind of quote unquote off label, but if a doctor feels that based on your unique circumstances that a booster shot's appropriate, then they can certainly order those and get an additional shot. As it is right now, I believe just the Moderna and the Pfizer mRNA vaccines are the ones that are boosters, just because the J&J, the different technology, and that one didn't come out until about March or so. So we haven't quite gotten to that 8 or 9 month window. So I don't think we'll see boosters on that one just yet. And then there's some controversy about if you got the J&J shot, should you get the mRNA as a booster, and will that give you even a little extra protection as well? So those are still big question marks that I've seen, and I get those questions quite a bit. But if Dr. Papa is your doctor, or if your doctor feels it's really important for your health to get a booster shot, we're now at a point where they can be ordered, and I believe we'll start rolling them out pretty soon for people that are really high risk, as well as healthcare workers, first responders, the folks that are facing COVID right now. So Heidi, thank you for that question. And hopefully it doesn't create too much technological challenges. I tried to kind of bump folks up as a panelist, and I see Mary W. Is on, and you can see her. So you had a great question that I honestly would never be able to answer in a million years. I'm hoping Dr. Papa can, is asking about the inflammation score. What does it mean? And you had some specifics in the box. So thanks for sharing your story, and I'll kick it over to Dr. Papa. Maybe you could chat a little bit about inflammation and inflammation scores and how to interpret.
Do you have more specifics on the inflammation score? It's not, and was that from a hematologist or?
And Mary, you have to click your mute button so we can hear you. Ah, there we go.
Yeah.
Ooh. Can you hear her, Alex? I'm having a hard time.
No.
Yeah. For some reason, Mary, we're having a hard time hearing you. I'm not sure if your microphone's not picking up very well, but we may have to go back to the old chat box again. But yeah, for some reason we can't. I'm not sure. Maybe it's on my end. Okay,
No,
maybe you can type it in the little chat box if you have fast fingers. Yeah, still can't hear.
No.
All right. Well, we will definitely come back to Mary W. and feel free to type in. One of the questions is Allison stole mine, which I was going to ask you too, is have you been seeing in your profession a rise in blood disorders post-COVID? So maybe you could speak about with COVID and long COVID and post-COVID, what are you seeing on the blood disorders and blood clots and all that stuff?
Well, I can't honestly say I've seen too many, an increase in blood disorders post-COVID. It's kind of hard to tell if people who show up with various blood issues since COVID, if it was related to an infection or not. Some may have, some may not have. Blood clots are definitely more of an acute situation. People with an acute infection with COVID, usually more severe cases, although it can happen with minor cases too, will promote blood clotting. So in that sense, we've definitely seen a rise. But I'll tell you, clotting disorders, blood clots in general, are epidemic proportions well before COVID. It's easily the most common thing that I see. At least 1-2 patients a week, sometimes more, newly diagnosed blood clots. And several reasons. I don't think it's any more common than it's ever been in the past, but certainly the awareness and the diagnosis. I know the emergency department is acutely aware of patients coming in with signs and symptoms that could be a blood clot, that do that workup immediately because it can be life-saving. It's very important to make that diagnosis. And we find a lot that way. And the medical community in general is much more aware. But it's a huge problem. And I would say about 40% of patients that I see have an underlying, what we call a hypercoagulable state, where they have an identifiable issue, either genetic or acquired, that will lead to blood clots. And I think the other 60% probably have it too. We just haven't discovered those yet. And I tell patients all the time, when I learned the coagulation system, 35 years ago, whatever it was, I thought it was by far the most complicated process in your body, maybe aside from the way your brain works. And I said to myself, great. We spent months of my career learning this. We have this down. There can't be any more. It can't be more complicated. And yet, as the years go on, more and more factors and cofactors and promoting factors and braking factors are found to create that delicate balance. So there's a lot of things that can go wrong, although 24/7 it usually goes right. So it's not surprising that in what is arguably one of the more complicated systems in your body, remember it goes everywhere, blood's everywhere, and that has to work a certain way all the time. So it's not surprising to me that there's many people with blood clots. COVID has accelerated that somewhat, and that it can stimulate some of the inflammatory markers in your blood or the immune system, and overload that clotting system to lead to a blood clot. But I don't want to, if there's questions here, I'm glad to entertain. I see a lot more names popping up.
Yeah, I kind of clicked on everybody to give them the opportunity to talk too. So now, sure. If people are comfortable, you can unclick the mute. And for some reason, we were having trouble hearing Mary. I'm not sure if that's a Mary thing or if it's a me thing. So there's a chance if we can't hear you, then we'll have to go back to the old chat box. But I thought I'd give it a go. And so that would be helpful. I was trying to kind of interpret what Mary's question might interpret. So I'm thinking probably not a sedimentation rate, because that's usually higher than 3. So I don't know if maybe it's like a CRP or a plasma viscosity or something like that. But there are definitely some generic markers of inflammation, and they can be a little tricky to interpret even for us on the medical side. So that was sort of my guess, but we'll see if we can get some more data on that one.
Sure.
Excellent.
Does anyone else have a question they want to type in or ask? Or
yeah, if you do, that would be awesome. And if not, I was going to invite Veronique, who put in the comments that she loves your dedication, and I asked her if she'd be willing to share. So I did kind of bump her over too, and I think you should be able to unmute. Would you mind kind of sharing what made you decide to join us tonight and what's on your mind?
Oh, I just want to support Dr. Papa whenever I can, because I've just found him to be an amazing provider throughout my journey with my rare blood cancer / disorder. I was diagnosed a few years ago and started seeing specialists in New York City, because it is a rare condition, and realized that I really needed to be treated by someone locally who needed to monitor all of my all the factors in my blood, and got concerned because, oh boy, Newport Hospital is tiny compared to Sloan Kettering in Manhattan. And turns out I could not have landed with a better doctor. He's just so open to hearing what I have to say and listening to other experts and being part of a team. And that to me is just made my life so much simpler. And I could not be happier with the care that he provides and his diligence in how I'm doing. It's really refreshing, to say the least.
And that goes double for me.
And that was my husband saying, that goes double for me.
Sure.
Nice.
Yeah.
Well, thank you.
You're welcome.
Very sweet. We're definitely very fortunate to have Dr. Papa. And I think it brings up a couple of points that I wanted to make just to highlight. Is number one, I think, people may not realize the access point that they have to, as cutting edge and world-class hematology and oncology care that you can get right here in Newport, which I think is probably worth talking a little bit about. And maybe, Alex, you can talk a little bit about how you do connect with some of the bigger cancer centers in the country in terms of New York and Boston. And we have some formal relationships with them, even on the research side as well. So maybe you could kind of walk through a little bit of kind of how we do stuff in Newport, bounce you up to the bigger places if it's necessary. If you have something really rare or unusual, kind of get the treatment plan, and we can kind of treat people locally in that whole arrangement. Because I think that's really one of the highlights of the whole program that we have in Newport.
Oh, sure. Rare disorders are rare, but once you figure out what it is, just because it's rare doesn't mean it has to be treated at a certain place. Depends what the treatment is. In the previous patient, who's very kind words, she had an unusual problem. It's sort of rare, but I guess if you're a hematologist, it's not that rare. And, really the treatments can be administered, easily in a place like Newport Hospital. You just need to be willing to do it and get the proper data. But the larger institutions have the advantage of are able to accrue a lot of patients just by referrals and have more experience, perhaps on an individual level, disease by disease. And as it filters down to the community, we sort of are more generalists, because we really, in a community like Aquidneck Island, you have a population of about 60,000 people, and the catchment area is a little larger. So, you can't really super specialize in one disorder because there's just not a lot, but it's relatively easy to learn about that disorder and converse with the expert who knows more about it than we might. Although, and I'm sure they would admit too, they know more, but it's not that much more. There's a few nuances. Our general training is pretty broad, and then a lot of us will go into subspecialties even within oncology and hematology, and migrate to a larger center where you can have enough patients to see in that specialty. But most of the generalists like us have at least seen or heard of every disease process. And again, the communication between physicians in our specialty, I think, is excellent. You could pick up the phone. I personally know people that have invented the drugs that a lot of you are on, that have won Nobel Prizes, that have worked in the research lab, and also the clinicians that work and do research and see patients in the big centers. And when I started, I was sort of, I don't know if intimidated is the right word, but they're like everybody else. Their goal is for the patient that you happen to be looking at that moment to get better, and are very willing to share the information. If some of the technical, perhaps surgical aspects of things, you might need the expertise of a larger center. Perhaps some experimental treatment protocols, although we have a lot we have a Brown Oncology group that has a lot of treatment protocols we have access to here in Rhode Island. But for your blood disorders, let's say, even cancer disorders, unusual and rare doesn't mean we can't treat it. It doesn't mean we don't know much about it. It just means there's not a lot of it out there, but we certainly can take care of it here.
Excellent. And then one of my team members, Liz, asked a specific question about the connection between Lifespan Cancer Institute and Dana-Farber, which I know gets quite a bit of press. Maybe you could kind of speak a little bit about how that relationship works, and if you find that to be a good sort of avenue to tap into the specialists you were just talking about.
Well, when I started here, well before Lifespan Cancer Institute, when I started here in '91, there weren't any formal relationships, but I can tell you, I quickly learned everyone at Dana-Farber that I needed to know based on what the patient I wanted to send had. So in essence, the relationship is really communication. It doesn't have to be a written contract. If you have with a certain disease and someone that has expertise in that disease, and I always say we're fortunate that Dana-Farber is less than 50 miles away. And I never ran into a situation where they said, no, we're not going to see someone. So that's why I never wanted patients to feel that they had to try to guess where they had to go for their problem. You come here first. We know if you need more expert opinion or a second opinion, and we're glad to do it. And it's really easy to do. It always was. Formalizing it makes it easier. Certainly with the computer system, they have the same system that we have. If you go to Dana-Farber, if you went there last week and now I'm seeing you in follow-up, a few clicks and I have all your data. You don't have to remember all the details as your mind is swimming trying to navigate through this. So that has been a major plus, which, the elation on patients' faces when I'm, looking at the computer and I already know what happened last week and we're already ahead of the game, has been a big plus as well. But that, for the individual patient to patient, that relationship has always been there. And there's really no excuse ever to not use it. And we have connections all over with our colleagues in oncology and hematology, and can find the right person. It doesn't always work. I mean, things are not always as simple as they sound, and even a common disease or can have an unusual aspect to it. And, it can be 99 times and the 100th time it just doesn't work, but it doesn't mean we can't try easily, actually. So I see that a question.
Well said. I agree. I think this day and age with the technology that we have, if you can pick up the phone and call somebody, there's no reason why we can't tap into the brains, especially the more cognitive specialties. If you need surgery or something that can
Do we have
questions about von Willebrand's disease, which I think are really interesting? Certainly come off mute and add to it, but I saw your question about being more common in the Newport area. That's not something I've heard before, but may very well be the case. And then certainly Irish descendants and other ethnicities, sometimes we'll see higher numbers. So Alex, maybe you can talk a little bit about von Willebrand's and what we see around Newport.
Yeah, von Willebrand's an inherited disease that basically makes you more prone to bleeding. It has a wide range from mild to severe. Most luckily are on the milder side. It's rare to see a severe case. Usually those are diagnosed when you're the pediatric population. I never thought about whether it's more common here, but we do have it is genetic. There is a predilection to Northern European ancestry. So, I suppose we would see more than you would in some other populations based on that. It's not an environmental thing at all. It's just the ethnicity of the area that might make that more common. There's another disease called hemochromatosis, which is an overload of iron that definitely is more common here because the gene is more prevalent in Northern European ancestry. So if you live in an area, for example, Hispanic or Asian populations is very rare. So if you're in a patient population that's predominantly that, you're going to say, gee, hemochromatosis is a rare disease. You come to Newport, not so rare. So, and von Willebrand's is sort of along those lines too. But it's not if you live here, you're more prone to get it, sort of thing.
I know from a public health standpoint, sometimes living under high tension power lines or near a popcorn factory and things, sometimes weird stuff can pop up like that. But I don't think there's anything funky like that going on in Newport. But you're right, we do have a pretty broad population of different backgrounds.
We do have a lot of more than usual melanoma, skin cancer. And again, that makes sense. All you have to do is look out the window. You have a predominantly fair-skinned population and a lot of beaches. So that combination's not, that's right for skin cancers. You don't have to go far to sunbathe, and you just happen to have, at least in the past, a more predominantly fair-skinned population. So if you didn't, and sun was tougher to get at, that disease wouldn't exist. So it's sort of an environmental risk, I guess.
Absolutely. And to pivot a little bit, I don't know if Jay Souza was on our last community lecture series with Dr. Sam Eaton, our urologist, who is going to be doing all sorts of fancy procedures at Newport and is already. But there's some questions about PSA. You may be able to see it, but just for if anyone's not looking at the chat box. So it looks like, PSA was normal 1 to 4 for years, and then shot up to 23. Got the call to let your husband know he needs to see a specialist, but it seems like there's a little delay to getting in until mid-September. So maybe you could speak a little to PSA and prostate stuff, and then maybe a little bit to kind of more that broader question of when you hear the big C word or a worry for the big C word, how quickly do you need to get in? How urgent is it? Maybe there's different answers to that question, but I know that comes up a lot. Is I want to see Dr. Papa yesterday, but
right,
what's the best way to handle that?
Sure. Well, specifically for the PSA, an acute rise to 23 doesn't always mean that it's cancer. Of course, that's what you want to rule out. Inflammatory problems with the prostate, prostatitis. Sometimes when you get a very rapid rise, it's usually not cancer, because cancer usually won't rise that quickly. But that's the diagnosis that has to be ruled out. So there's 2 answers to your question about how quickly things need to be seen. There is the patient perspective. When you get that call, the only thing that you hear is you have cancer. If you get a call that you have a blood disorder, you need to see a hematologist. A lot of people are worried that they have a leukemia or a blood cancer. So to try to see people expeditiously, you want to at least allay that fear, which oftentimes is easy to get rid of. But it's important, and sometimes something as a provider we need to realize there are limitations to how many of us there are and how quickly we can see patients. And I try to triage referrals as they come in. There's people that need to be seen today or tomorrow. There's people that's less severe that could wait a month or even more. We kind of let them know that this is not a major deal. It's okay to wait. So how long you wait is very individualized. It's nice to have some communication go out to the patient, to the severity of what is going on. But in general, for a hematologist or an oncologist, if you have something that is severe, you'll be seen expeditiously. Can't think of any one of us that would sit on something that needs treatment sooner than later. So in general, and again, the definition of how soon or how long is different. For some people, a week or 2 weeks is too long, and for some it's okay. So that's a difficult. Everyone's problem is their own. It's unique. And we don't expect people without medical knowledge to be able to make that distinction. It's your problem, so of course you're worried about it.
Yeah, I definitely see that pretty acutely in the emergency department, where people come in with all sorts of different things. And I used to joke with people that if you come in and you immediately get whisked into the back and there's a doctor and a couple of nurses and everybody standing over you immediately, that's usually a really bad sign that something really is wrong with you. Whereas if you sit out in the waiting room for a little while, it's not what anybody would want, but it usually means that you're probably going to be okay. So it's kind of a broad brush, but yeah, I agree. We definitely have a couple of tricks to dig into things, and the people that set up the appointments aren't going completely blind either. They're taking a lot of information into account to try to get you set up. But with that being said, if you're concerned, I definitely encourage people to speak up, talk to your doctor, talk to the referring doctor. You can be the squeaky wheel as well. And at least you can get a little more information to reassure you if you feel like you're waiting and you have lots of questions and you're not getting them answered.
Right.
Heidi, do you want to come off mute? It looked like you had some comments about your new relationship with Newport after being at Rhode Island Hospital for a while. I'd love to hear it.
Yeah. Yes. Do you hear me?
Yes, we
Yes.
can. Thank you.
So, like for 50 years. And I've been in Jamestown for 30, and it's just within the last 5 years sunk in that, well, I think that's been developing at Newport Hospital too, with its relationship with Lifespan. So now more and more I'm oriented to that. And most recently was referred to Dr. Papa, which was a very good move. And I don't have to drive up to Cranston and Providence anymore on top of that. So I'm really delighted about that because there's so much offered there. And it's such a civilized place. When you go to the lab or you go for an x-ray or whatever, physical therapy, it's just really a pleasure.
Oh,
So
good.
thank you.
I'm glad you're having a good experience.
Yeah, I am. Thanks.
Well, I definitely am a little biased being the chief medical officer at Newport that I think we do things a little better in Newport than anywhere else, but we do lead the system in our patient experience, and it's a lot to do with Dr. Papa and his team and the other teams throughout the hospital, and the fact that, well, all the hospitals really try to put the patient first. You know, when you're talking about little smaller numbers, it's a little bit more manageable. It's an island. People know each other. You have the personal relationships, and that goes a really long way. And the nurses and the doctors that work in the hospital know each other. They're invested in the community. It's a culture thing that is really hard to replicate anywhere else. So I'm really proud of it. So I'm glad that you feel that. That's awesome.
Thanks.
Yeah. And then it looks like Veronique had a couple of questions about reversing conditions that are caused by genetic mutations. And she put PV as an example. Maybe you could speak to environment, nutrition, things like that. What sort of things can you do about genetic mutations? Any feedback for Veronique? I'll click on that so you can read it.
Well, in general, we may or may not see the era where the genetic issues are able to be fixed. I don't know if anyone has heard it's called CRISPR technology, CRI, like CRISP with an R on the end of it, where actually pieces of faulty genes can be removed and replaced with normal ones. There is some major breakthroughs in sickle cell anemia where the defect is a relatively specific area where it could be replaced and eliminate the disease. Not commonplace. That we're really talking specialized research type of situation. But you know, every treatment that everyone's on now at one time was in someone's laboratory and was considered research and experimental, and then it gets out there and it's commonly used. You know, we use a lot of, in cancer, a lot of immunotherapy where the treatment uses your own immune system to eradicate or treat the particular cancer. Instead of traditional chemotherapy, which has a lot more side effects. And the results have been stunning in a lot of patients, elderly patients, sick patients that are able to tolerate these treatments with very few side effects. And in a lot of cases, their disease goes away. You know, the only good thing about getting older in this is you have this perspective. You know, like I look back 30 years ago, and some of the drugs that we use now, without even thinking about it, didn't even exist then. And I wonder, you know, how did we do it? And yet, at each point in your career, everything that you do is cutting edge. But the cutting edge now is a lot sharper than the cutting edge then. And these were all processes that were in someone's research lab at one point, not knowing, is this going to work or not? Hours and hours of dedication and failure before you nail it and hit the right thing. So anything that you can think of and that we can talk about probably will come to fruition at some point in time. Whether we'll see it, whether it will aid us may or may not be true, but it's going to happen. And the gene technology is definitely going that way. I'm convinced the human genome has been mapped out anyway. The technology is there where you can kind of look and see where the defects are, what's going to happen, what's not going to happen. And then the next step will be trying to fix it. But I don't want to get into there's ethical considerations there too. But looking at it from a pure medical science point of view, it will happen. I'm convinced of that.
Liz had actually typed in a question about patients at Newport participating in clinical trials. And I know the answer is definitely yes. In other areas, we certainly enroll patients in clinical trials and do some research and get them plugged into research that's happening at Brown and at Lifespan. But maybe you could comment, or you have any examples of patients that have been enrolled or maybe are getting experimental drugs that are not yet approved?
Yes. Yeah, we have access through Brown Oncology, Lifespan, mostly out of the Providence group. But we have two of their physicians come here, Dr. Dizon, who does gynecologic oncology and breast cancer, and Dr. Safran, that does gastrointestinal malignancies. I hear physically here once a week, and have developed some of those protocols themselves, actually, personally. So we have easy access within the Lifespan system. And then if we don't have anything that can help, and we really have exhausted or we determine that a patient is eligible for a protocol, even experimental, again, living in the Northeast, you don't have to travel far from major centers, be it Dana-Farber, be it Yale, be it Sloan Kettering, and even elsewhere if need be. So the key is the initial contact here. Once that occurs, the world is really, is all open. It's very easy to get the data. It's very easy to see what trials are open and not open at various places. The access is there. Even the National Institute of Health, the patients that go back and forth there. And a lot of these research facilities are very happy to have local people sort of, monitor the patients and keep an eye on them, especially now with the ability to share information being so easy, so that they don't have to, go physically back and forth if it's not necessary. Kind of like Zoom. You're right. At home. You're answering your question. You don't have to be sitting here. So
that's right. I'm talking to a world-class hematologist oncologist, and I'm sitting outside on my little patio under an umbrella so I don't get skin cancer. Can't get any better than that. But talk about the current cutting edge. You used to have to get on a plane with a big briefcase full of folders and records, or then the fax machine. We could move stuff around that way. But now we can shuttle your data around electronically, and you can stay in your pajamas and get some answers. It's pretty amazing. Correct.
And one of the examples I like to use that works really well at Newport, being a user-friendly facility. Remember the days where you had to see the physician and you needed the blood work done, and oftentimes you'd have to go maybe days before, wait for it to get faxed or sent over. The vast majority of patients that I see, they have the option of going the same day. And I joke, since I'm a hematologist, I'm looking at blood counts. And if you go to our lab and you have your CBC done, by the time you walk down the hall and into the office and wait for me to be seen, your result is in your record, like from there. And there's no excuse for it not to be, really. That the test only takes a few seconds to run. We have the machines that are up to date. You stick the tube in. Really, by the time they put the bandage on, that result is coming through. And in the past, you get a little piece of paper that had the level on it, which I thought was great. Now it's right there. It beats you up the stairs or down the hallway. Again, is it going to make you more curable or make your disease better? Maybe not, but it certainly makes the process a lot easier. And that's magnified here because we have such a smaller, I hate to say it's a small place because it's big enough, to meet the needs of the population. It's the appropriate size for the population of the area. If suddenly it doubled, we double too. So small doesn't mean, it's just a physical number, but, it's easier to navigate.
Yeah, if you think you're at a small place, get a sore throat on Block Island and see what's small. There's some places that are on islands that are
right,
pretty tiny, but no, I totally agree. And I'm obviously an ER doctor, so one of the reasons I love that instant gratification, as soon as I ask a question, I'm already trying to hit the refresh button and looking for the answer. But that instant gratification definitely is helpful to get the information you're looking for, which is awesome. And I wanted to invite Mary. So Mary was a longtime listener, first time question asker, and she's been very patient. But she wanted to ask a question a little bit more about the BRAF colon cancer gene. And then we had another question from Judy T about colorectal cancer in patients over 75. So kind of a whole bunch of stuff there about, gene markers, colon cancer, colon cancer over 75. So do you mind taking a stab at some of those questions?
Yeah, the colon cancer, again, very common disorder. In the past, let's say 20 years or so, a lot of genetic markers have been found. The BRAF mutation is a mutation that's found in actually several cancers, not just colon, and can be targeted. There are a couple of chemotherapeutic agents that target it, and you have a better outcome. Although the BRAF mutation can portend a more aggressive cancer, at least we have a viable treatment for it. Melanoma is another cancer that will have BRAF mutations seen with it quite a bit as well. There are also several other colon cancer markers called microsatellite instability that are routinely assayed by our pathologists here. You don't have to ask for these special tests. When your colon tumor is removed or is biopsied, they're routinely done and are part of the official pathology report to tailor therapy. So again, there are immunotherapies available for colon cancers that work well in those specific examples. The over 75, I think you might be alluding to, do you need to get a colonoscopy over 75? I hate age limitations. I really don't understand. I've never really followed, I guess is the word, that you shouldn't do something just because someone is above a certain age, because life expectancy is rising. And in fact, if you make it to 80 or 85, let's say, which is, most people consider that old, okay? But you're more likely to make it to 90 or 95 than someone who's 70, statistically speaking. You've already demonstrated, the ability that, things are working pretty good if you made it that long. Secondly, the treatments that we have now, the immunotherapy I was talking about, really age doesn't really make that much of a difference anymore because the toxicity is so low that I've treated patients literally 95 years old with metastatic cancer successfully with very little toxicity, where maybe even 5 or 10 years ago, they would have been told that, you need palliative care or hospice care. So getting back to the recommendations, I think that needs to be revamped. Now, these are all personal opinions now. I'm not, there are standardized guidelines for these things. But, those of you that know me, patients that know me, I'm not going to use your age to do or not do a test. So just because you're 75 in 5 days doesn't mean that, we're not going to do the colonoscopy or the mammography or anything that I think is indicated. Now, I have a skewed population. I'm already seeing patients at risk. So for me, the decision is easy. People would argue in the general, population, you would be over screening, but that's, a different discussion. And I'll tell you a quick story. I saw a patient came in about a month ago that I had seen about maybe 8-10 years ago, happens to live on Aquidneck Island, happened to be a high school teacher of mine back in Cranston, Rhode Island, 100 years ago, had a problem that required a transplant that they do in Boston. And he was about a year or two above the age cutoff. So I called the physician in Boston that I know would be able to to take care of this guy. And I said, I have this patient who would be a great candidate for this, transplant. And I went through the whole scenario. I said, he happens to be, I forget what the age cutoff was, but he's 2 years older. I said, if I lied, if we transposed the numbers on his date of birth, and I said, he's 68 and not 72, you wouldn't even think twice and transplant him. And he said, you're right. So they transplanted him, and now 8 years later, he's in remission. So again, age is really more so than ever, really, it's important. I mean, the older you get, the more things can go wrong. There's no question about that. We have to bear that in mind. But it's not a absolute barrier to treatment, just the number. It's what's behind that number. And, I like to look through people. It doesn't really matter what they look like outwardly, because, in cancer and heme, we're always thinking of physiology, what's going on the cellular and molecular level. And if that's working, pretty good at whatever age you are, we can treat you. Sometimes younger people, it's just not working well and you can't do much either. So really, it sounds like such a cliche, but it's the truest cliche. It's rare to have two patients that are alike, even with the same disease, even twins. You just have to individualize that, which I think makes it a lot more fun for us anyway, instead of just compartmentalizing and stereotyping everything. But that's just me. So
yeah. It's funny because as an ER doctor, I tend to look more at what do they look like from the doorway instead of the molecular level. And I can tell you that I've seen patients that are in their hundreds that would kick my butt in tennis and look amazing.
Right.
And you're right, their age doesn't even matter. And then I've seen patients that are in their 30s and 40s that you walk in and you go, oh my God, what have you been doing? You look like
Right.
You've maybe made a few decisions I might not agree with, and you're in pretty rough shape. So yeah, I agree. Age is definitely relative. And I've seen people that are younger than me that look pretty rough, and people that are 90 or 100 that had outrun me. It's pretty awesome, especially in Newport. You don't have to go too far. And there's a few of them on the call, I bet, today that are in pretty good shape despite the age. So
Right.
I agree.
Right. And I don't mind pointing out to patients their problems, what's age related and what's not, and what you can expect and you really can't fix, and what you might be able to fix. And oftentimes they can have two different things, same age, and something you can easily fix. Sometimes we can cure your cancer, but the arthritis we can't. So it's you can't even compartmentalize within a patient and generalize. So.
Absolutely. All right. Well, we've still got about maybe 5 or 6 minutes left, so we definitely have time for maybe 1 or 2 more questions. But I'm just excited to have Dr. Papa here on this little program, and I hope you guys take advantage of chatting with him, because, as he mentioned, really the first point of contact and the access point is right here in Newport. We can do the vast majority of stuff that you need for both blood-borne disorders and cancer disorders right here in Newport. And if you have something that's fancy or something that's rare or something that requires a research trial drug or something really exotic, then it's just a matter of a quick phone call or a Zoom meeting with a specialist up in Boston or in New York or over in Connecticut or elsewhere. So it's pretty remarkable what we do have access to, unlike I joked about Block Island or Nantucket or Martha's Vineyard. If you've ever been traveling to some of the islands that we are real close to, it's a little tricky to be everything to everybody, but I think we get pretty darn close to it, especially in this arena with Dr. Papa and his team. So please take the opportunity to ask a few more questions, and then we'll kind of wrap things up. But unless Dr. Papa, you wanted to talk about any other particular topics that might be of interest.
No, it's amazing breakthroughs have been made. It accelerates, year by year, which actually keeps me in the game. I think I'd feel badly stepping out because I'd be afraid that I'm losing some of the, missing out on some of these great treatments. And it's really been a remarkable renaissance in treating all of these disorders that we talked about today. And it'll get better. It'll just get better.
Absolutely. One question I had for you, Alex, and then I do what Mary looks like she put another question too about warfarin and things. So maybe you have time for both. But my question was just, the hospital's investing a bunch in diagnostic imaging. We're looking at getting an open MRI, new CAT scanner out in Portsmouth, some breast imaging, which is probably the biggest one. So 3D tomosynthesis and upgrading some of our technology. I'm just curious, especially on the cancer side of things, how much that technology and that information that you get from those devices kind of helps guide you nowadays in terms of how you treat folks. But feel free to jump on Mary's question about blood clots and warfarin and GI side effects and garlic if you want to hit that.
Warfarin is an old drug. It's a very good. It's effective. Has a lot of quirks to it. A lot of things affect it and don't affect it. In certain circumstances, warfarin is the best choice. One of the breakthroughs in blood clotting have been the advent of it's called direct oral anticoagulants, which are much more physiologic in preventing blood clots. And again, it's a case-by-case basis. The majority of patients can go off warfarin and go on Eliquis, Xarelto, Pradaxa. There's a whole bunch of them. Sometimes cost, unfortunately, is a factor that we have to deal with. We're usually able to get around it. But, warfarin, we can spend, the coagulants, we can spend 3 hours on the ins and outs of it. But, basically, a lot of things affect warfarin. The direct oral anticoagulants are much more physiologic. It's kind of like our immunotherapy or our targeted therapies. Too much garlic. The key with warfarin is when you're on warfarin, don't make any drastic changes in your diet in any fashion because it might affect it. If you eat the same thing all the time, we can adjust the warfarin to a therapeutic level. If you make a change for whatever reason, then let your provider know.
And it looks like maybe taking garlic instead of warfarin might be the situation, which, certainly there's things to diet and herbal remedies. Warfarin's a pretty powerful drug. So I wouldn't, in my mind, consider the two to be equivalent by any means. But you're right, garlic is a bit of a mild blood thinner. But that would be a good conversation to have with your doctor because depending on the reason you're on a blood thinner, I'm not sure garlic will necessarily get you there unless you're really eating boatloads of it, in which case it's probably better that we're on a virtual meeting and we don't have the breathalyzer going.
Yeah. The short answer is don't do it because if you have a condition that requires an anticoagulant, that's one that the consequences can be bad if it goes wrong. So,
absolutely. All right. Well, we're almost to the top of the hour. Dr. Papa, anything else that you wanted to share or wrap things up before we wrap up our show?
And I appreciate the support from the community. The best part of this is dealing with the patients. If it wasn't for that, it wouldn't be we wouldn't be doing anything. And I don't think I'm doing anything special. We're just doing what we're trained to do. And I appreciate everyone's support of the hospital. They try very hard to keep everything as cutting edge as possible, all the tools that we need to make the proper diagnoses and provide the proper care. They really do a great job at that. Always have. Yeah.
Well, as usual, Dr. Papa is being very humble, which is one of his key strong suits. So It's amazing to have world-class hematology, blood disorder, cancer care right in our own backyard, which is kind of remarkable. And like you said, it's a quick, easy phone call if you need to get somebody specialized, but I bet you he doesn't have to make too many of those phone calls these days because he's been doing it for a long time. So definitely rest assured that if you have any of those sorts of challenges, even the thorniest of blood disorders and cancer problems, we can definitely help figure them out. So talk to your primary care doctor, talk to your family doctor. If you do have any diagnoses that you're concerned about, we can definitely get you plugged in with the Lifespan Cancer Institute at Newport Hospital. We have urologists, we have other surgeons. Dr. Tassinari is one of our breast specialists. She does a lot of surgery there. So if you need surgery, radiation therapy, a tumor board, we talk with our radiation therapy docs and we can kind of get arrangements for that. Infusion therapy we do right at Newport. So if it's not right at Newport, it's very close by. So hopefully you don't need any of those things at all. And you can stay healthy and stay the heck out of the hospital. That's always my hope. Happy to shut the place down and we'll find something else to do with our time. But if you do end up needing Dr. Papa and his team, just know that they're there for you. They've been there for a long, long time and will be there for a long, long time to come. Maybe Dr. Papa not as much longer. We'll see how his career shapes up. He's been doing it for a while, but we're happy to have him on board and his some of his partners, Dr. Ingham, Dr. Diazon, Dr. Safran, the whole team that comes down right on site at Newport is really great to have. So thank you everybody for taking the time to join this program. Please reach out to us if you have questions. And next month, we're looking at lining up some programs about the Autism Project and some things that we're doing about younger people with some challenges on the neurologic and behavioral side of things. So that should be kind of fun. So keep you posted on that one. And Dr. Papa, thank you again for taking the time to do this. Really appreciate it. And thank you for all your decades of dedication to Newport Hospital.
My pleasure. Thank you all. Yeah.
Appreciate it. I'll see you in the hospital probably tomorrow.
Probably.
Take care.
Yeah.
Bye, everybody.
Bye.